cerebral vascular system, as well as sometimes even dealing with oncology or pathology. So they can go anywhere in the vessel or treating cancers, targeting biopsies, things of that nature. So this next slide shows pretty much a direct quote from the Stanford College of Medicine. They published a journal saying that IR procedures improve conventional surgeries, just period. The fundamental aspect of IR is to do less cutting and more safe. So instead of breaking all your ribs to tackle some sort of clot that's somewhere in your heart, we can go in through a small cut, maybe near your lower leg or your inguinal region, to access that area. IR is a global thing these days. You can find hospitals that practice interventional radiography all around the world. However, we know that X-ray was founded by a man named Wilhelm Röntgen, and that was on November 8th of 1890 something. I forget the exact year.
Fine.
However, we've made a lot of strides since then, and now that we have augmented reality, people are considering, how can we reduce dose? How can we reduce radiation and improve our patient care? So we've gotten some new ideas. From the very beginning, we had X-rays. We discovered it was a new thing, great. Lots of dose though. How could we reduce that? Well, let's try and make it digital. Let's try and improve our images, make sure that we can see everything clearly without having to redo it again. If we also improve the accessibility so that hospitals can contact each other and contact the patient, they won't have to stay at the hospital the whole time. If we integrate digital data into our images and into our health care, we can improve patient care by getting the information and the doctors to the patients immediately. With that, we have teleradiology. Since teleradiology, we've implemented AI into teleradiology to not only help improve our diagnoses, but also to help improve our just method of contacting other people. Now we've got doctors on the phone and AI to supplement those doctors that are in your phone, whether it's through a virtual meeting or through a virtual appointment or whatever. But finally, we come to augmented reality, in which you can just throw on that little headset I got and have an actual chat with your doctor. They can pull up your past scans, they can look at your stuff, and they can figure out a plan of action without you even having to leave. So, we're gonna take a couple steps back, and I'd like to get a little bit interactive. What do we see in the top left?
Barium swallow.
That is a barium swallow, which requires what?
Barium.
Barium. That's
Radiologist.
radiologist. Okay, let's take a little tiny step back.
Fluoro machine.
Radiation, fluoro machine. Right. So while they're doing this, this patient is receiving what? Radiation? Dose. So how could we improve that? By not having dose, not having radiation? We sort of need it though, to see everything that's on the inside. Similarly to here, we're using radiation to capture this sort of joint space in action and the actual muscles, tendons, everything to see the functionality of this person. But down here we have a CT of the brain, which is very high dose. And it takes things in images in very thin slices so that we can specifically target areas of interest. So with that, I find that we have a lot of problems in radiography. So let's just talk about those real quick. Did you know that 10% of patients are injured under the care of healthcare professionals, meaning that 1 out of 10 patients that we see is probably gonna get hurt at some point in time, whether it's through radiation, through an actual operation, through some form of procedure, or maybe the patient just fell. You know, stuff happens. The average patient in a CT scan, whole body scan, is going to receive 620 millirem, which may not seem like a whole lot, but that is, the estimated annual dose to the average American is 620 milligram, which means that as they're walking around and doing their day-to-day lives, they're getting this from terrestrial, cosmic, and natural sources of radiation. However, if we come down here to the estimated absorbed dose for the whole body CT scan, that is 1,000 milligram. So every day that you walk around and do your normal thing is pretty much just over half of what you would get from a CT scan. And all that stuff adds up, and that's what we like to call dose creep. With dose creep, you can tend to accumulate dose over time, which could affect the stochastic effects that you're gonna receive or experience. Over 15 million Americans undergo some form of surgery every year, and that was provided to me by the American College of Surgeons. So from 54 lawsuits against interventional radiography practices, provided by that guy, who cares? Most common complications are another operation becomes absolutely necessary to save that person's life, and that happens 28% of the time. Patient death happens 22% of the time. Hemorrhage, which is bleeding of a vessel, happens 19% of the time. Puncture and perforation, also 19% of the time. Continued pain, 15. Infarction, which is sort of a heart attack or some form of cessation, is 13%. Embolism or thrombosis, which is basically like blood clots, 11%, and the list goes on. So these are all complications or injuries that the patient could or would sustain from interventional radiography practices. However, these are a lot of big numbers, and you may have noticed that this would total out to be something more than 100%. That isn't a mistake. That's because a lot of the patients that get injured in interventional radiography will sustain multiple injuries per exam. That did look good. Harris Health System boasts a volume of 18,207 total surgeries annually on their facts and figures webpage. But out of the 29.7 million inpatient admissions in 2016, 2.3 million had at least one IR procedure, according to the Stanford School of Medicine. Now, this doesn't necessarily apply to Harris Health. This almost 30 million is accounting for the entire United States. So every hospital and every place that has interventional radiography, that's what was counted here. With that, so if we could take that 30 million, 10% of those inpatients are treated with IR services, and that is a generalized fact. If we were to come from the UK side of things, there is a hospital called the Great Ormond Street Hospital, and they treat about 3,500 people every year. Of that, 40% of their operations are central venous access, which is similar to that operation that I mentioned earlier, in which they go through the inferior vena cava and tackle a situation that's happening up here, because they're trying to access one of those central veins using a Hickman catheter. Here I have a couple images. Two are from the actual operating room. One is a CT, a cross-sectional image. This case study was an individual, they got shot in their liver, and the bullet went all the way to their right hepatic area. And looking at these images, you probably wouldn't be able to tell that, right? It just looks like the biliary tree, but then a bunch of nonsense. This is what our radiologists have to deal with. And I know that they learn this stuff, but wouldn't it be much easier to be able to actually see and target what you're looking for while you're actively looking at the patient instead of having to go into these reports looking, all right, now let me go cut them up. No, we should be doing live displays of images superimposed onto the anatomy so that we can provide the best patient care possible. So, I would say one of our biggest issues in radiography or in imaging in general is the fact that all of our imaging needs to be orthogonal, in which, or I should say, we need multiple views of the same part to demonstrate where things are actually at. Because if we were to look at these image artifacts here, who's to say that's not on their back? Who's to say they didn't ingest something and it magically spells that out? These are piercings that are on the front, but you never really know. So if we were to not have orthogonal images, we would need to do repeat exposures every single time we saw that patient to make sure we truly knew where their issues were. And with that, ionizing radiation has a tendency, or let's say a stochastic sort of effect, to harm us no matter what level of radiation we get. There is stochastic and deterministic. Stochastic, as we know, is probability based. Any radiation that you receive, you might get this, you might get that. However, this being more detrimental is deterministic, meaning that these people, this patient, received so much dose to this tiny area that their cells started to behave in this fashion or decay in that fashion. So I bring to you different ideas and concepts to advertise for the HoloLens and the Omnify XRTM, in which all of the spatial resolution features are improved. The price is kind of egregious for the consumer. The HoloLens 2 is currently still at $3,500, which should not be for the average patient, but I find that that's well within bounds of a hospital to add into their IR rooms or into their radiography practices, because as you may know, it takes millions of dollars just to furnish one radiography room. So the products as of October 2023 have been made available and FDA approved to be pretty much widespread across the United States. In other words, these products and the software that we use can be used to improve our patient care and interventional operation practices pretty much as soon as possible. So with that, we have accurate 3D imaging that's integrated into AI, and we choose to superimpose that over our anatomy to provide real-time images of what we're actually doing. Anybody can use it, anybody that's in the room. This is a dramatization, basically a bunch of images from their past screenings or exams superimposed to show what we're actually doing in real time. Here is their actual promotional video. We have the attending doctor with all of his pertinent information. This is our radiologist, or I guess our tech, but they're not really doing anything. You know, they're not shooting. They don't have to, because they already did. And the doctor has all that information in the HoloLens already. Down here, you can see their road mapping. So they took a wire or a catheter and advanced it into the patient, and it actually lets you know how far you've advanced without needing another image. So you've shot your first one, now we're gonna go in with Sono to give us live updates and see without exposing our patient. Another pie chart. So with these head-mounted devices, we've got doctors and attendings saying that 63% of those doctors and attendees said that HMD head-mounted devices interventions were based and are more efficient and more effective. 7% of those attendings said only 2 studies claim that the implementation of head-mounted devices would not be beneficial. However, 15% and another 15% said not only was this technology useful in the actual surgical environment, but it could also be useful for educational environments. And I have a little video up there that demonstrates what we're going to be doing if we do go with this device or system. This is the cartoon version of it, and it may seem a little silly or kind of video game-ish, but to take something as simple as this and apply it into surgery, there's so many different applications. If any of you have actually been in the IR room, let's say they're doing an angio on the foot, you have a sort of spaghetti noodle bowl of a bunch of different vessels, and while the doctor is trying to access it, they're just twisting and turning and exposing. Did that work? No, let me try again. No, let me try again. And every single time they try again, they have to do another exposure. So it's a ridiculous amount of radiation that goes to the patient over simple and easy mistakes. So that brings us to our devices. This is the HoloLens. It's pretty much like any other VR ever, except it's got an actual projection into the real world. You can see what you're doing. There's no camera. There's no real obstruction, in which this one, there's no lens, you know? We have 5 cameras here, but it's still obstructing your view. With the HoloLens, they don't want you to be obstructed. They want you to see what you're doing and then superimpose that data in real time. With Omnify XRT, many of you partnered with GE to develop this AR system utilizing the HoloLens software. So Microsoft and Philips developed and patented a software called Azurion, which also received FDA approval back in 2018. So this is what the Azurion suite looks like. Kind of similar to that concept we just saw, except you get a real image and real road mapping, and it's just dramatic, the change of what we've had and what we now have. So this is my sources page, but I would like to go to YouTube and play that video, so we're gonna go back to one more. So this is a short 44-second video. I don't think it has sound, sorry guys. As you can see, they're using sonography to provide live data. Then they're implementing the past CT scan to actually build something for them. And as you can see here, they were advancing a catheter and using the road mapping and subtracting to see what vessels are important to them and actually proceed with the exam. So not only is this showing you here the ease of access, but there's voice commands, and if you see with his fingers here, he's controlling everything with just swiping his fingers. So if he doesn't want to look at CT anymore, he can swipe. Or he can say, if his hands are busy, Azurion, next slide. Show me the MRI. Show me Sono. Show me live. It's tactile and it's also audio enforced. So it just really, really exemplifies the ease of access. So with that, we're going to go to our sources page again, and I'll open the floor to questions if you'll have them.
So are they actually using this in hospitals for surgery now?
Some, but it was hard for me to find the actual operations, and like for HIPAA's sake, they can't really post those.